We've talked about these topics for segmental facilitation, reflex inhibition, axoplasmic flow, but not in a lot of detail. And we're going to increase that detail a little bit today. This is really not so much for right now, but for future courses where we'll be talking about this in more detail and bring it into use much more frequently. But let's give you an example of it. Let's discuss it a little bit now, and then you can start looking for it now before you fully understand the implications of these. So we're going to be talking about segmental facilitation, reflex inhibition, and axoplasmic flow compromise. So let's start with segmental facilitation first. It's central sensitization of a certain type, and the effect is to lower the response threshold at the spinal segment. So for a given input, the response is larger than it should be. Cause of it is generally given as aberrant input over a prolonged period. Now, nobody seems to understand what the prolonged period is, how long it is, and it's presumably it varies from person to person and from stimulus to stimulus. I'd say it isn't just aberrant input, because aberrant mechanoreceptor input results in reflex inhibition, and it's difficult, which is not quite the opposite of segmental facilitation, but it's clear it's nearly the opposite, and it seems not to be central sensitization. In either case, most of the effects with mechanoreception problems or with reflex inhibition is the opposite of what you see with segmental facilitation. So I see inadequate or aberrant mechanoreception as being an unlikely cause of reflex inhibition. More likely, I think, is prolonged nociception. And then what we see with this clinically is hypertonicity. The distribution is segmental. The effects are hypertonicity in the muscles throughout that segment. And like all of these characteristics, they're more profound the closer to the spine where they're seen, the more distal out. But they should be present throughout the segment. Sometimes they're so minor that you just can't detect them. Not the clinical methods anyway. So hypertonicity, non-fatigable weakness in those muscles. The scratch test is positive, so that when you scratch, particularly again centrally along paravertebral areas, you'll see that the red mark that you should get with a scratch is reduced over the segment of the skin of the segment that is facilitated. And this is because, presumably because hypertonus in the vascularity there. So you either see an absence, a whitening of the area instead of the reddening, or you'll see a narrowing of the scratch at that area. It can be a very rapid phenomenon. You need to see it really quite quickly. The deep tendon reflexes are brisk, but they're not pathological. There's no clonus in them. They're just brisker than you would expect them to be. You may be able to spot trophodema, and again, closer to the spine than further out, and you can indent the trophodemic tissue. This is swelling in the skin, but you can indent it by poking a matchstick into it, and you'll see the pitting edema there sometimes. And all of these signs improve with wobbling anywhere within the segment, whether you wobble at the neck or you wobble down in the foot. Input will change these signs for the better. Again, the further centrally that you wobble, the more profound the effect of the wobbling is. And all you're doing is inputting mechanoreception, and of course what that's doing is defacilitating the area. It won't last, it's not a treatment, but it is an examination technique and a preparation technique for some of your treatments. The effect of this is to reduce range of motion actively, and because of the extra tone. And it also gives the bone an abnormal axis of movement, so it's competing between its natural axis of motion and the one that the tight muscle is putting through it. So you can get some abnormal forces. So the speculation into these abnormal forces can damage the ligaments, the joint capsule, and even the joint surfaces. The other effect, the clinical effect that's potent, is weakness. And the weakness then can destabilize the bones that are being controlled by those muscles, and the muscles can then degenerate because of that weakness. They tend to try and overwork and they degenerate because of it. Reflex inhibition. This is inhibition, pure and simple inhibition of muscle strength and reduction in tone of the muscle. This is much more local. It occurs, the evidence of it occurs around the joint that is producing inadequate proprioception. And that loss of proprioception can be from a number of causes. Hypomobility, obviously, you lose movement, you lose proprioception, but also hypermobility. You're getting movement in ranges that are inadequately supplied to give you proprioception. So in those ranges, you lose proprioception for the amount of movement that's occurring. So it's a relative thing. It's difficult to imagine a condition where you will get excessive proprioception, maybe some of the neurological conditions like Parkinson's, perhaps, but I really don't know. But from an orthopedic locomotor system perspective, other than neurological, it's difficult to see anything that will give you excessive proprioception, which would be an argument for that causing segmental facilitation as well, but I can't see it. Characteristics, the weakness is patterned, it's often in a PNF pattern around the joint where you find the inhibition. The weakness is breaking in type. It will generate some force for a while and then suddenly give way. And this is best seen with an eccentric contraction taken at the end of range. So you're pushing into that weak movement and it will suddenly give on you. Local wobbles now, only local wobbles will reduce the inhibition. So you have to wobble the joint that's causing it. Doing a central wobble doesn't work for you. So if you're trying to distinguish between reflex inhibition weakness and segmental facilitation weakness by wobbling, and you don't know which one of the two it is, you're better off wobbling further away from the joint where you find the problem and seeing if that reduces it or improves it. If it does, then at least some of this is segmental facilitation. If it makes no difference, but then when you wobble the joint itself and that improves it, then it's reflex inhibition. Axoplasmic flow. This is disruption of protein flow through the core of the nerve. And you get flow antegrade and retrograde away from the center and towards the center. So retrograde is towards the center, removing metabolic products, metabolites back into the center, going out are the trophic nutrients for the end organ, and also from our perspective, what's important is the replacement of synaptic transmitter substances. You lose some of these every time you get a crossover the synapse. You lose some. Most of it's taken back, but you do lose some, and that has to be replenished on a basis. Now, this flow forwards and backwards is a continuous stream of protein. It's not impulse-based, so it's a continuous stream. And what causes the loss of this is mechanical obstruction to that flow. This could be compression, torsion, twisting, traction, crumpling, anything basically that can disturb the nerve can disturb this flow. This can be a single crush incident, which you'll see with radiculopathy, but it can also be multi-crush, so that you have smaller areas, one or two sites or more sites, gives you this double multi-crush syndrome. Characteristics, the distribution is varying depending on where exactly the compromise lies, and it can be at the radicular level, in which case you'll have a radiculopathy, or it can be somewhere in a peripheral nerve and the radiculus. What you'll see is the signs and symptoms will be distal to the distal block. So the distribution is a lot more variable. You'll see fatigable weakness, no other neurological signs of this. Deep tendon reflexes are good, sensations good, and so on. But it's very fatigable, this weakness. It can be dependent, position dependent. So if I can move the nerve by moving the limb or the neck, come to that to a different position and relieve that pressure, then you can get the flow back again. Now, it's not so much that it blocks it completely. You don't have to think about this flow stopping and starting. So unless you get a complete occlusion of the nerve, there'll also always be some streaming going on. So you've got a pressure building up. When you relieve the block, that pressure is rapidly transmitted down the nerve. That change in pressure rapidly transmits down the nerve. And so you see a fairly rapid improvement in this. Local wobbles, unless they're changing the position, local or segmental wobbles, unless they're changing the position of the nerve to accommodate this flow, are not going to have much effect on this. Effects, weakness, and this can look very much like a radiculopathy, which it is, but it's not an electrical radiculopathy. This is pure loss of transmitter substances. If the slow flow is lost, then basically you get trophic malnutrition of the end organ, and that can lead to degeneration. Now, you can pick up fast flow loss by the fatigue or weakness, but slow flow loss, you have to deduce that it's lost by the loss of fast flow. I think if you've got fast flow loss, you can assume you've got slow flow loss, and all of this needs to be treated anyway. So as a very quick introduction to these three phenomena, and it'll be central to everything when you start moving down the line a bit with this.